Diagnostic test. There is enormous difference in the management of chronic CHF and pulmonary edema in the office and ambulatory-based setting. The key is to identify the setting, ED versus office or clinic, and whether acute symptoms of dyspnea are seen at the time of presentation. Echocardiogram, most important of all the CHF tests. All patients with CHF must undergo an echocardiography to evaluate ejection fraction. There is no way to distinguish systolic from diastolic dysfunction by history, physical examination, or other tests such as EKG, chest X-ray, BNP. Transthoracic echocardiogram (TTE) best unit test to evaluate ejection fraction. Multiple gated equation scan (MUGA). Nucleoventriculogram, most accurate test, most precise or wall motion abnormalities, used in rare cases. There is apparent need to administer maximum amount of local lubricant chemotherapy to a patient to cure his lymphoma, but not so much as to cause cardiomyopathy. Transesophageal echocardiogram (TEE) to evaluate heart valve function and diameter. TEE is not necessary for evaluating CHF. Brain natriuretic peptide (BNP) level to evaluate acute shortness of breath. The etiology is unclear, and you cannot wait for an echo to be done, nor normal BNP excludes CHF as a cause of the shortness of breath. Other tests that are used not to diagnose CHF but rather to identify the cause of CHF. A diagnosis of CHF is a clinical diagnosis based on history and physical with a type of CHF determined by TTE. Chest X-ray misses nearly half of cardiomegaly. Test used to determine etiology of CHF. Test etiology of CHF. EKG, MI, heart block. Chest X-ray, dilated cardiomyopathy. Holter monitor, focus examine, arrhythmias. Cardiac catheterization, precise valve diameter, septal defects, CBC, anemia, thyroid function, T4 TSS, both high and low thyroid levels causing CHF. Endomyocardial biopsy, rarely done, includes infiltrative disease such as sarcoid or amyloid when other sites for biopsy inconclusive. Biopsy is more accurate test from some infection. Swan can right heart catheterization. Discriminate CHF from ARDS, rare, not routine. Treatment of systolic dysfunction. Systolic dysfunction, lower ejection fraction managed as follows. AC inhibitors or ARBs for all patients of any stage, at any stage of disease, any drug in the class has beneficial effects. Those with a cough from AC inhibitors should be switched to ARB or sacubitril plus valsartan. Sacubitril lowers mortality. Patiromer or zirconium for megalemia is an AC inhibitor or ARB is needed to delay progression of renal failure or decrease mortality in CHF. Sacubitril or valsartan, combination of an angiotensin receptor blocker, neprilysin inhibitor (ARNI) is an alternative to AC inhibitor or ARB. Beta blocker, not proven that any drug in the class that has beneficial effects. Only bisoprolol, and carvedilol have been proven to be effective. Metoprolol and bisoprolol are beta-1 specific antagonists. Carvedilol is a non-specific beta blocker that also has F1 beta blocker activity. Benefits of beta blocker likely stem from anti-ischemic effects, reduced heart rate, leading to decreased oxygen consumption, and antiarrhythmic effects. Beta blockers used to treat systolic dysfunction are metoprolol, carvedilol, and bisoprolol. Mineralocorticoid receptor antagonists (MRAs), first-line agents in CHF, inhibit the effects of aldosterone, spironolactone. Eplerenone, an alternative to spironolactone, has no antiarrhythmic side effects or to lower mortality. Thyroxine controls dyspnea but does not lower mortality. No positive inotropic is thyroxine, milrinone, aminone, dobutamide have been proven to lower mortality of CHF. Diuretics control symptoms of CHF but do not lower mortality. Immunotherapy of CHF with low ejection fraction often includes a loop diuretic plus AC inhibitor or ARB. It does not matter whether the diuretic is furosemide, torsemide, or bumetanide, spironolactone, although a diuretic is not used at doses where it has a diuretic effect. It is the most common cause of death from CHF. See arrhythmias and sudden death. Ischemia provokes ventricular arrhythmia, leading to sudden death. Over 99.9% of patients with CHF are at home, not acutely short of breath. If they undergo sudden death, the physician never sees them. Beta blockers are antiarrhythmic and anti-ischemic, so they prevent sudden death. shortly beta blockers, and the acute treatment of CHF. Where the management of a patient with severe CHF who develops amasia, switch spironolactone to epinephrine. Where the answer is still the patient is still dyspneic after using AC inhibitor, beta blocker, diuretic, digoxin, corticoid inhibitors, sacubitril/valsartan used instead of AC inhibitor. Sacubitril is added only to an ARB. This neprilysin inhibitor provides a mortality benefit for cytolysis function. Cardiolysine nitrate used when either an AC inhibitor not an ARB can be used as a vasodilator therapy. May add epidioxy to AC inhibitor or ARB in some patients. Ivabradine is a nodal inhibitor of funny channels that lowers the heart rate at it to systolic dysfunction as a pulse of greater than 70 ppm or beta blocker can be used. Ivabradine decreases symptoms, side effects include transient visual disturbance. Tip: don't walk into assembly step using the exam without being 100% clear on which drugs lower mortality and CHF. Poor prognostic factor in heart failure. Clinical high New York HNY class, hypertension, tachycardia, thirst, venous distension, and S3. Labs: hyponatremia, elevated PNP, renal insufficiency, EKG, QRS greater than 120 milliseconds, left front block, echocardiogram, severe reduction in ejection fraction, pulmonary hypertension, diastolic dysfunction, right ventricular function impairment. Associated condition: anemia, atrial fibrillation, and diabetic bladder. Strategies for CHF treatment: the two other treatments are associated with a mortality benefit in CHF. One implantable defibrillator, and two biventricular pacemaker. Implantable defibrillator for those with an ischemic cardiomyopathy and ejection fraction less than 35%. These devices have a much less as a 25% relative reduction in the risk of death. Remember that arrhythmia leading to sudden death is the most common cause of death in CHF. A life vest is a temporary externally wearable defibrillator. Two biventricular pacemaker. The biventricular pacemaker is indicated in those with dilated cardiomyopathy and ejection fraction less than 5% and wide QRS greater than 120 milliseconds. They have persistent symptoms. The wider the QRS, the greater the benefit. The wider the QRS, the greater the benefit of a biventricular pacemaker. Do not confuse a biventricular pacemaker with a dual-chamber pacemaker with a fire in both an atrium and a ventricle. The biventricular pacemaker synchronizes the heart when there is a conduction defect. Many patients who would otherwise be heading to the cardiac transplantation have had their symptoms markedly improved with the biventricular pacemaker.